We are live now.
Okay. Has the Ravindra Singh joined? Anand,
Not yet,
Ravindra
sir.
No, not yet, sir. Not yet. But
okay, but we can continue with first session is 15-20 minutes by the definitely. We had a morning talk with him, so I think. Gupta ji was supposed to come, I think, on the screen actually. SB Gupta.
Dr. Kane messaged me, but
Gupta ji को भी फोन कर दो जरा.
I see Dr. Gupta. He's there.
Gupta is adjusting his camera.
Right.
I'll not be there for the as video, but I welcome all of you on behalf of CSI Mumbai chapter and wish you all the best for today's webinar.
So, Dr. Ramesh, you want to take over? Or,
yes, yes. I think they are okay with the audience has been joining now. So then we can start our first talk. Sajid?
Yes, we can start now. We are live on all the platforms.
Okay, okay.
We can start. I'm helping Dr. Kane to live join in.
Great.
Sajid, everything ready from your side?
Yeah, everything is ready, sir.
Acha, ठीक है. So we have how much audience has joined so far?
I need to check, but in the meantime, I'm helping Dr. Kane to join in. He is finding some difficulty. So let me help him first.
Okay, okay. Kane anyway talk is second. You tell me when is actually to start. So we are ready all.
Sure, I will let you know.
Dr. Anand, कैसे हैं आप? How are you?
Sir, very good, sir. Good evening. I am fine, sir. How are you?
Was all well.
Gupta ji,
not working.
Dr. Kirti, welcome.
Oh, good evening, Dr. Saab. How are you?
आपने काफी दाढ़ी वाड़ी काफी बढ़ा ली है.
लगता है लॉकआउट से बाहर नहीं आया.
अपने आप ही हुई है. मैंने कुछ नहीं किया इसके लिए.
लॉकडाउन का सर है. लॉकडाउन का सर है.
But it doesn't fit. A mask doesn't fit properly with a beard. So you get some bacteria inside, virus inside. So it's not scientifically correct to have a beard.
I guess if it'll be a bigger harm if I'm going to be breathing them out though.
The filter.
I think we should start with this
okay,
topic, because we're well past the time.
We start it, just already 5 minutes late. So people will go on joining.
Yes.
So good evening to everybody. On behalf of CSI Mumbai chapter, I welcome you on this seminar on aortic stenosis. I think the structural heart diseases have made a lot of improvement in the last 10 years. TAVI has become now a regular procedure. Though India's number is quite small, I think slowly we are growing in the numbers actually. The indications are growing and growing. As our aging population will increase, I think we'll get more patients for the eye. It will become like a regular cataract or prostate something. We have some eminent personalities here. Anand Rao and Dr. Kane will be moderating both the session. And we do expert speakers, Ravindra Rai, who has done more than 100 procedures himself and is associated with more than 500 procedures from Jaipur Eternal Hospital, who has worked with Dr. Sameer Sharma, and Dr. Nitin Burkale, who has done a pioneering work in echocardiography and very eminent cardiologist from Thane Jupiter Hospital, will be taking the session on the. And we have two experts, Dr. Mehta, Harish Mehta, and Dr. Kirti. Have been associated with this work, quite big number in Mumbai. I think Kirti and now Ganesh has done like maximum number of cases probably in Mumbai city actually. So I welcome all these expert panelists, and I think the first session will be 2D echo assessment in the aortic stenosis. And to moderate this session, we have Dr. Anand Rao will be moderating. He will introduce Nitin, and I think Nitin will talk, and then later on the second session will be by Ravindra Rao, which will be talking exactly on the TAVI procedure and its actually complications. So I will hand over to Dr. Anand Rao to take the first session of the echocardiography. Over to you, Anand.
Thank you very much, sir. And good evening, one and all, Dr. Kirti Punimaya and Dr.
Your
Harish Mehta,
volume is
the
low. I think you
expert
can increase
panel.
the volume.
Yeah.
Voice is low.
Yeah. So, good evening and welcome to this evening symposium on TAVI. We have a great expert panel, Dr. Kirti Punamia and Dr. Harish Mehta. And today we're going to have both discussion on both sides on self-expanding and balloon expanding valves. TAVI is a procedure which actually has taken up quite well in city of Mumbai. We were, however, lacking compared to our counterparts in North India and South India. But now Mumbai is taking up the pace, and we should be doing more of these procedures on a regular basis. We have a wonderful. Before that, my co-moderator Dr. Kane is going to join us in a short while. Before that, we have the first talk by the eminent Dr. Nitin Burkule, who has been a great teacher, echocardiographer par excellence, and his talk is something we are all waiting for. And so, Dr. Burkule, if you're ready, you are going to speak about echo insights in TAVI. Thank you very much.
Thank you, Dr. Anand. Is my screen visible to all?
Yes, visible, I think.
Yeah. So we will be discussing the evaluation of aortic stenosis in this era of TAVR. What are the newer insights that we have got? TAVR is a disruptive technology because we have to now rethink the management, because with the partner 3 coming in, we have to now rethink about the asymptomatic severe AS with normal ejection fractions. And with partner 1, cohort A and B, we also should rethink about our sick heart failure patients, especially those with low flow and low gradient. Now, this is the definition of aortic stenosis. Everyone knows that you have to have mean gradient above 40, valve area less than 1, and the indexed valve area below 0.6. We'll see a case. Is a 52-year-old male, hypertensive, completely asymptomatic, and he's on the regular echo follow-up, BP 140/90, body surface area 1.9. He has this calcific aortic stenosis, LVH, and this is his EF is normal, but you can see that his global longitudinal strain is low. And 1 minute, I'll have to get into fine. 1 minute, I'll just share my screen again. I think there was a certain crash. Yeah, I'm visible again. Yeah. So this is his EF. This is his echo, and then this is his GLS, which is less, and his peak by mean gradient is 74/45. And that's not the only thing that we should be talking about. We have to indicate that this particular gradient has been measured at a stroke volume of 40 ml per meter square with a transvalvular flow rate of 277 ml per second. Now, how do we get it? Now, the flow is measured as a cross-sectional area into velocity. For cross-sectional area, we measure the radius, and with pi r square, we get the cross-sectional area, and then we get a velocity time integral, the modal velocity, and we get the stroke volume from that. And from the aortic flow, we get the systolic ejection time. And when you divide the stroke volume by systolic ejection time, you get the transvalvular flow rate. Now, the cross-sectional area is the Achilles heel of echocardiography. You can substitute the cross-sectional area by the CT-derived cross-sectional area of LVOT, or a 3D TE-derived short axis area of the left ventricular outflow tract. There is a hemodynamic classification of aortic stenosis depending upon the flows. The normal flow is a stroke volume index above 35 ml, and low flow is less than 35 ml. And the high gradients are mean gradient above 40, and the low gradient is mean gradient below 40. From this, we get a classification of aortic stenosis, which is either a normal flow low gradient, normal flow high gradient, low flow high gradient, or low flow low gradient. And we know that we are not going to discuss the normal flow low gradients because they are probably measurement errors. High gradient A's are very easy to take decision about the intervention. Problem is with the low flow low gradient aortic stenosis. Now we'll come back to the patients with severe asymptomatic aortic stenosis. Is it a low risk condition? Absolutely not. It is not so benign. Let us look at this recent history of the asymptomatic severe AS from this group from Austria. Now, 1/3 of these patients develop symptom on the treadmill. Almost 8% of them die in between the follow-up visits to the valve clinics. In almost half of them have abrupt severe onset of heart failure. And this abrupt heart failure leads to a higher surgical mortality and poor long-term outcome. And almost 1/3 of them will reach the clinical endpoint by 1 year and more than half at the end of 2 years. So it's not at all a benign condition. What about the ejection fraction cutoff? Now, the current guidelines indicate that you can send an asymptomatic severe AS patient to surgery if the EF is less than 50%. However, is it correct? Because if we look at the natural history of these patients, here on the y-axis is the survival and on the x-axis is the years of follow-up. The red line indicates the survival data of patients with ejection fraction less than 50, and the green line shows you the survival data of ejection fraction between 50 to 60%. Both of them are almost parallel and almost following each other. So EF less than 60% itself looks to be a problem. If you look at the hazards ratio of risk of death, on the y-axis you have got the hazards ratio for risk of death, and on the x-axis is the ejection fraction. Obviously, as the ejection fraction will go down, the hazard of death in AS is going to go on increasing. However, the inflection point is not 50%, but somewhere between 55 to 60%, that the hazards ratio start suddenly rising. So the thing is, we are not looking at the sick myocardium. Now, the sick myocardium, we can look by the global longitudinal strain that you get it on the echo very easily. But now, even on the cardiac MRI by feature tracking, we can reproduce the global longitudinal strain, which is nothing but the myocardial deformation. What we want to see is the myocardial fibrosis, whether it's an interstitial fibrosis or whether it is a replacement fibrosis. Now we have got lots of markers of myocardial fibrosis. We get beautiful T1 maps on the MRI. We get the extracellular volume fraction, and we get the late Gardner enhancement, and also on the echo GLS. For every 20 millisecond increase in the T1 value, the mortality actually increases by 28%. And when there is a ECV expansion and LG, the mortality goes 10-fold high. So how do you integrate that? So patients with an ejection fraction more than 50%, just look at their echo GLS. If the echo GLS is above 18%, you can follow them up every yearly. If it is between 16 to 80%, follow them 6 monthly. And if it is less than 60%, get an MRI to look for the myocardial fibrosis. And if it is already there, better intervene him. Now we'll go to the other extreme, the patients of severe AS with heart failure and low gradient aortic stenosis. Now these patients with low gradient aortic stenosis are divided into those with low ejection fraction and with normal ejection fraction. Those with low EF are called as classical low flow low gradient AS, while those with normal EF are called paradoxical low flow low gradient AS. Now those with the low EF or the classical ones are of 3 varieties: those with contractile reserve, without contractile reserve, or pseudo AS. That means there are moderate AS, but because the LV doesn't have energy to open the valve, they are behaving like severe aortic stenosis. While the paradoxical can also be true and pseudo, and also it can be a measurement error. So we'll see a case of a classical low flow low gradient aortic stenosis. 70-year-old lady, hypertensive, class 3 dyspnea, has a low flow low gradient AS with LV dysfunction. And this is a calcific aortic stenosis here, and the LV is quite depressed. And you can see even in short axis, there is a dysynchrony. And her mean gradient is 30 and her stroke volume is 30 ml. So she's a low flow, low gradient severe aortic stenosis. These are the patients who should go with the low dose dobutamine. Now, why do you give low dose dobutamine? Because you want to recheck the gradient and aortic valve area at a stroke volume about 35 ml per meter square and increasing the transvalvular flow rate about 200. And if you don't reach it, at least do mathematically projected aortic valve area, and I will show how. Secondly, the another aim is to look at their contractile reserve. Suppose with dobutamine, your stroke volume increases more than 20%, it's a contractile reserve positive. If it doesn't, it's a contractile flow negative. Now, this patient undergoes 5, 10, 15, 20. We see the LVOT and aortic gradient, and this is what we get. Now, these are the dosages increasing from 0 to 20. Look at the stroke volume, 52, 46, 57, 47, 44. There is no change in stroke volume, rather there is a fall in stroke volume. Look at the transvalvular flow rate, they never exceed 200 ml. And what happens to the valve area? 0.58 to 0.64. So this patient doesn't have a contractile reserve. So what do? One way is that one way is to plot the flow rate on the x-axis and plot the valve area on the y-axis and just project it to 250 ml and see whether he still lies in the severe range, or the best is to look for the CT calcium score of the aortic valve. If it is more than 2000 for male or more than 1200 in female, it is definitely severe aortic stenosis. If it is less than 1600 in male or less than 800, it is very unlikely to be severe aortic stenosis. Now, why we needed this? Because in the SAVR era, we knew that those who have got contractile reserve, as is shown by this red graph, they have an excellent survival after valve replacement. However, if you don't have contractile reserve, then actually even your survival after valve replacement is not so good. Not only that, you have a very early acute mortality. However, what happens in TAVR? Now, this is the TOPAZ TAVI registry. So the red bar shows you the patients with contractile reserve and the blue who do not have a contractile reserve. Now, whether you have a CR positive or CR negative doesn't matter because the EF increment is the same after TAVR. So also, if you want to look at the mortality data for contractile positive, contractile negative, it is the same. That means TAVR helps for both the patients, whether there's a contractile reserve present or absent. So the thing is, the low dose dobutamine doesn't have a predictive power for EF recovery or MES events post TAVR in the patients of this classical low flow, low grade aortic stenosis. And TAVR seems to be the treatment of choice for this group of patients. Now we'll look at another patient with a depressed LV function and a severe calcific aortic stenosis. And this is a patient with a obviously low flow, low grade aortic stenosis because the stroke volume is 29 ml per meter square and the mean gradient is 24. So it's a low flow, low gradient severe aortic stenosis. So we put him on the low dose dobutamine, 5, 10, 20, take the LVOT and aortic flow, and then we'll see the results. Now this is the dobutamine dose goes from 0 to 20. The stroke volume increases from 50 to 69. So 20% increment is there because 20% will be like increment of 10 ml. He's already gone from 50 to 70. So he has a contractile reserve. His mean gradient has increased from 24 to 32. But what has happened to his valve area, which from 0.78 to went to 1.2. So that means though he has a contractile reserve, he's a pseudo aortic stenosis. That means these are the people with moderate aortic stenosis and LV dysfunction. So what do you do for them? So though the dobutamine differentiates into those with flow reserve and without flow reserve. Those with flow reserve and those who are pseudo severe AS are recruited in the TAVR unload trial. And if this trial also comes positive, then probably we will not need this low dose dobutamine for classical low flow, low gradient severe aortic stenosis if all of them are going for TAVR. Then we'll look at this group of paradoxical low flow, low gradient. That means these are the low gradient AS with normal ejection fraction and they are in heart failure. Now this group had got a very high mortality. We'll look at a case, 80-year-old lady, hypertensive, CKD, LVF, class 3, NOIHA, and presents with heart failure. Now, these are the typical LVs of these patients. They are very small LVs, hypertrophied, big atrias. They have a lot of mitral annular calcifications, and they have a severe aortic stenosis. They also have a PH, and you can see the stroke volume is 28 and transvalvular flow rate is 160. So she is a low flow, low gradient severe AS, and she already has developed PH. Now, these patients have typical characteristics. They are elderly, they are women, they are hypertensive, they have severe exercise intolerance, they present like HEPs, they have multiple comorbidities. Echo shows severe LVH, very small LV cavity, low global longitudinal strain, low E primes, reduced LV compliance, and they have a lot of myocardial fibrosis. Now, these are the patients who in the surgical era had a better survival than medical management, but their survival was still very poor as compared to the patients who had a normal EF and high gradient. So despite these patients having normal EF with a low gradient, they have a very high mortality even after surgery. Now, there are no specific TAVR trials looking only at this group. Now, these patients have a restrictive LV and a lot of patient prosthetic mismatch. So the thing is, we have to be very cautious in sending them for a TAVR. You have to reconfirm that, see that there should be a very severe LVH. You should have very good BP control and reassess the gradients. They should have very significantly reduced longitudinal strain. The AVA should be well below 0.8. Mean gradient should be at slightly above 30. You should meticulously calculate the stroke volume. And the best thing is go again for a cardiac CT for the aortic wall calcification. When you are 100% sure, then only send this group for a TAVR. Then the intra-procedural monitoring during TAVR, as we know that the TT versus TE, though TE gives excellent images, you need a GA, so most of the interventionalists has given it up and you do transthoracic, but I'll tell you, it is challenging. Patient is on the back, you have got a limited access to the chest wall, and you have to take good images, and that too rapidly. So the thing is, during the procedure, you look for the depth of the implant here. Then you look for the new regional wall motion abnormalities. If any coronary gets occluded, you look for intraprosthetic leak, look for the PVL, the paravalvular leak estimation, look at the prosthetic gradient, look for a new onset of pericardial effusion. And if you're doing anterograde crossing, then in the T, you will guide the septal puncture. PVL estimation is the crux of the issue. On the fly, AR index is always better because you look at the difference between the end diastolic pressure minus the LV EDP and divided by the systolic pressure. So this is less than 25%. That has got a higher mortality because the PVL is high. On the echo, we look at the thickness of this jet called as vena contracta. If it's more than 6 millimeter. And also we look at the extent, the circumferential extent of the PVL. And if it is more than 30%, so I'll show you this case. First thing is that you use all the possible windows to search for the PVL, like it is seen here in the 5-chamber view, but not in the long axis view. Then again, in a skewed 5-chamber view, you are seeing it better. Then this is in the skewed long axis, you are seeing it better. This is the way you look it in the short axis, and then look at the vena contracta area. And you can add all the dots together. If it is more than 10 millimeter square, that is significant. And then look at the circumference. Now, if you look at, this is the 180 degrees. So this is somewhere around 25% of the circumference, the circumferential extent. So anything about 30% is severe PVL. Post-TAVR follow-ups, you have to see their prosthetic mean gradients regularly. If they are increasing more than 50% of the pre-discharge, you have to be careful. Look at the restriction of the leaflet motion. Look at the thickening of the leaflets, because they will tell you the early valve thrombosis. And also you will grade the PVL if it still persists. So in the post-TAVR follow-up, now this is the study of the partner 3 cardiac CT sub-study presented by Dr. Makkar. And this is done with the cardiac CT, 4D CT, and this is called as HALT, or the hypo-attenuated leaflet thickening. You get an attenuation like this, and you get a restricted opening. This is a severe HALT. Now, this particular HALT behaves very erratically. The CT was done at 30 days and at 1 year in this sub-study of partner 3. So at 30, those patients who had HALT, 56% of them at 1 year did not have HALT. While those patients who did not have HALT at 30 days, 21% had a new onset of HALT at 1 year. Now remember, those patients who had HALT at 30 days and also at 1 year had a higher gradients. So also the patients who had HALT had higher cardioembolic events. Now, between TAVR and surgery, obviously the surgery patients were on oral anticoagulant while the TAVRs were on the DAPT. So at 30 days, the TAVR had a significantly higher HALT. But at 1 year, the difference vanished because many of the surgery patients also must have gone on DAPT. So that is how it's a dynamic process of HALT. The editorial for this particular study suggests that you go this way, that you do a serial transthoracic study. If the gradient goes above 50% of the discharge one, then do the cardiac CT. If the cardiac CT shows HALT, that is a leaflet attenuation and restricted mobility, go on oral anticoagulant for 3 months. If the gradient vanishes, and the thickening vanishes, mobility improves, stop oral anticoagulant, keep a surveillance. If it reappears, then go for a probably a VKA rather than a DOAC, and then again repeat the same cycle. So dear friends, we know that there are certain clinical features where you favor TAVR, like a high STS score, say 4% or above, age about 75, frailty that is depending for at least 3 or more activities of daily living, severe restricted mobility, previous cardiac surgery, or certain anatomical like expected patient prosthetic mismatch, feasibility of iliofemoral access, severe chest deformity, past radiation, porcelain aorta, or the sternal adhesion of functioning graft. So this is the broad overview and the role of newer imaging techniques in the TAVR era. Thank you.
Thank you, Nitin. I think for excellent talk. I think Anand will take over. And I think the next session, Dr. Kane joined us actually. Dr. Kancham Kane. Thank you for covering this all. Thank you. We'll have a question answer session at the end of both the talks, I think.
Yeah, I've joined.
So Dr. Kane is there. Kancham. So you can take over as the moderator for this. And I think you have some introductory slides. And then I think Ravindra will take.
Do I share my screen?
Hi, good evening, Dr. Kane.
Yeah, good evening. Good evening, Anand. Yeah, nice to see all of you. And I think Nitin has made, I would say it's a very, very strong lecture. Nitin, I have to ask you so many questions myself to understand, because there are lots of things, but I think we are coming to the questions at the end. So I'll just try, and I have a few slides because I have been asked to just present a little bit prelude to master TAVR person speaking. So can you see my screen?
Yes, sir.
Yes, now.
Yeah, so I will be just presenting 5 or 6 slides of how the TAVR has evolved, so that, and then we come back to the TAVR proper, so that we can learn on this. So just wanted to see, we all know that we have seen aortic stenosis, and whenever any elderly patient of aortic stenosis is to present, we would say nothing can be done, because the surgeon would say, no, he's too high risk, he's got renal problem, he's frail, nothing can be done. And usually these people live their life till and just wait for a death sort of a thing. That changed, and that changed according to me. 1 or 2 slides I want to share, which I feel are very important for all of us to understand how an ingenuity of an human being can lead to discoveries and lead to better quality of life for all human beings. This is the man who should be credited. Many of us don't know him. Henning Andersen is a physician from Denmark who had that idea after the stenting came. He thought, why can't implant a stent? He took the sternal wires and put a valve there and implanted it in animals with his friend, and then went to this institution to tell other people that this can work. As usual, you know, anything new, you are ridiculed. So he was extensively ridiculed by his institution. But he worked on it, and he came out with a paper, a poster in 1992. The reason for putting this is Andreas Grunzig, we think now is the biggest man we know of in intervention, had to go through similar thing. Andreas Grunzig presented a poster in 1975 to show his early work, and nobody went to see the poster because nobody knew him and nobody knew what is angioplasty then. Same thing happened to Henning, and when he presented this patient paper at ESC 1992 poster, you can see him standing alone. There's nobody there. That's what happens. And subsequently, we all know this was in 92. 10 years later, Cribier did the first aortic valve replacement without surgery. So when he went through the mitral valve, it was a retrograde attempt. And from then on, we went on. And I'll just show you how the progress is in a short while from now. And just to show you, Henning comes back again. In 2011, he's standing here by the side of a patient who has undergone aortic valve TAVI. And you know who the patient is? The patient is his own father. So he was so happy that something which he thought of and went on to become reality helped his own father to live many years with the TAVI program and the TAVI valve. So that's the importance of knowing how discoveries can help people live longer. So in short, now initially as this TAVI and the other valves have gone through research methodologies like no other procedure in interventional cardiology or in medicine. It went very, very systematically. The initial patients which were taken were those who were reviewed by surgeon as inoperable. So it started with a partner trial with the Edwards valve. They took two groups, one inoperable and other high risk for surgery. And they found that both the groups did very well. Inoperable was compared with medical treatment. High risk was obviously compared with surgery. So 2011-10, this trial started. In 2011, we got sanction, FDA sanction for the first sapien valve, and 2014 for the self-expanding valve. And then on sky's the limit. Then the next step was intermediate risk. 2016, we got publications for intermediate risk, and the valve got approved, both self-expanding as well as balloon expanding, one after another for intermediate risk patients. And for your kind information, in 2019, we have now publications and approval for low risk patients. So why this is important? Inoperable patient, high risk patients, and intermediate risk patients don't constitute more than 30% of total aortic stenosis. The major chunk of aortic stenosis is either low risk or it is asymptomatic. So that is why low risk is the highest group. So whether this TAVI will work in low risk or not was a big problem for all interventional TAVI people or structural heart disease people. And it is a real pleasure to say that with the work of Martin Leon, Popma, and many others all over the world, we have come to have FDA approval for low risk patients in 2019. So now comes the next one is, these are the presentations, Popma for self-expanding, Martin Leon and Mac for balloon expandable. So both the valves have got approved. So it's a very big thing for structural heart. And we know that this risk, when we say high risk, low risk, is basically it's a surgical risk, which is STS score less than 4% is low risk, 4 to 8% is intermediate risk, and more than 8% is high risk. These risks actually do not give the full presentation of a patient because a lot of factors like frailty and other problems are not coming into these risk factors because they were done mainly for surgery, not for TAVI. So this is a very, very pleasant thing that everything is now approved, even low risk are approved. So now obviously the structural heart disease people are wanting to go further. And what's the next step? Asymptomatic people. Large amount of aortic stenosis patients we know remain asymptomatic, or they restrict their activities and not to get symptoms. So it's a false sense of security that they have, and many of them have sudden death. So identifying asymptomatic who needs intervention is very important, and those trials are now underway. And TAVR in patients with aortic stenosis with heart failure is also under the way. So ladies and gentlemen, TAVR is like a train which is moving. It's like a fast train, but it is the fast train which takes all the stops because it has taken all aspects of patient presentations of aortic stenosis along with it. It has moved very rapidly, I would say, from 2011 to 2019. We are almost including all patients of aortic stenosis who have significant aortic stenosis and need some sort of an intervention. Thank you very much for attention. This is just a prelude. Now let me introduce Dr. Ravinder Rao again. I think he has been introduced before also. He actually doesn't need any introduction. But Ravinder Rao is the director of TAVI and structural heart disease at Eternal Hospital, Jaipur. He is a good friend and he is my younger colleague, I would say. And he has done his interventional cardiology fellowship at Mount Sinai, New York, which does the largest number of coronary interventions in USA and probably the world. So he's been trained in coronary intervention there, and they also do structural interventions. And some dedicated structural heart disease fellowship at Washington University School of Medicine, I think with Dr. Lasala, because I've also met him at one of the conferences, and they do a very, very large amount of work. He has done over 100 towers in Jaipur and over 500 in India. Highest number as a single operator in Asia. It's a very nice thing to know. He is the first to replace both aortic and mitral valve in the same sitting. He has proctored almost all the major centers in India and abroad for TAVI, mainly India and some of the centers abroad too. He is regularly invited to perform live cases in national and international conferences. And obviously, he is an expert in TAVI, in the mitral clip, mitral valvuloplasties, balloon, pulmonary valvuloplasties, and all sorts of procedures, valve-in-valve, bicuspid aortic valve, aortic aneurysm, complex coronary interventions also he does because he's been trained for that fully. And he also does peripheral intervention. So there are lots of other things I can say about Ravinder, but time is short. So I will ask him to give his talk on TAVI, how it is sort of, what should we know about TAVI? Ravinder, please. So I have to unshare
Thank
my screen.
You should.
Good evening, everyone, and thank you very much, sir, for those kind words. And thank you, CSI Mumbai and Dr. Dargar, for the opportunity. Hello, Dr. Rao. How are you, sir?
Good.
And Kirti Gunamia and Dr. Haresh Mehta. Hello, everyone.
Right.
It's my second place where I work, and I love Mumbai. So, without wasting any further time, I will start. We were discussing that what should I speak on Tower. So one important thing which I thought I should share with you all is the workup of Tower, and then I'm just going to share uh, because there are some experts in the panel as well and who are very good experienced Tower operators, and a lot of people have already understood about basics of Tower, and so we're going to discuss some, what are the complications or what are the changes which we can acquire during a Tower procedure. That will also help us to understand how to select a balloon expandable or a self-expandable valve, because at present we can tailor a Tower therapy for a particular patient. Uh, and it was a great knowledge sharing which was done by Dr. Kane, where he shared us the journey of Tower from high risk to intermediate risk to low risk, because
Okay. I'll talk to you later.
common belief that Tower is not for low risk patients; it is only for inoperable patients. So, without any wasting further time.
Yes.
So imaging for Tower, we need to look at two things when we are doing imaging for Tower. One is the valvular complex. So I don't want to call it as valve itself. We are looking at a valvular complex. And second is the access route. Why I'm stressing on the access route, if you look at all the trial, it was transfemoral Tower, which was statistically superior than a surgical aortic valve replacement in all the trials, partner 2 or partner 3. So we try to do all our Towers from the TF approach, either by fixing a blockage by doing a balloon angioplasty or doing something, and we would choose an alternative route only if there is no other procedure possible from the femoral access. So what is a valvular complex? Valvular complex includes the valve annulus, the valve leaflets, LV outflow tract, sinus of valsalva diameter, coronary height, sinotubular junction, ascending aorta. So look at so many things which we have to look at, not only the annulus itself. What is the limitation of an um, and cardiologist by Dr. Nathan Burkley? But the limitation of an echo is it is a two-dimensional structure, and the annular plane which you measure by the long axis, uh, the valve, you can never size a valve based on this dimension. That the reason is because the annulus is a three-dimensional structure, and on an echo, 2D echo, you are measuring only dimension. So what is the best way to size an echo, to size the annulus? It is the multi-slice CT scan. And the reason is because the echo is very much operator dependent. We need to find Dr. Burkley in each and every hospital to get those precise measurements. But CT scan is highly reproducible compared to an echo. These are the various measurements: echo, multi-slice CT mean diameter, multi-slice CT area, multi-slice CT parameter. And on the y-axis, it is the aortic regurgitation. So if you look at the assessment, if you assess the annulus based on the multi-CT scan parameter, the aortic regurgitation is least. That means you are able to size your valve better by a multi-slice CT scan perimeter and area. So for all self-expanding valve, it is the perimeter which is used, and for all balloon expandable valve, it is the area which is used. So this is the whole valvular complex which I was discussing about. It is the sinus, leaflet, sinotubular junction, ascending aorta, left ventricle, not really the left atrium, but anterior mitral leaflet, which is important. So what is annulus? So, for a surgeon will cut open the aorta, will remove the leaflets, and he can actually feel the annulus. But what is the annulus for an intervention cardiologist? So what I call it as is the fluoroscopic annulus or the interventional cardiologist annulus. It is the nadir of all 3 points, which the left coronary cusp, the right coronary cusp, and the non-coronary cusp, and they all are in a straight line and in the same plane. That is what the interventional cardiologist annulus is, and we need to understand the fluoroscopic anatomy to implant a valve in a better location. This we already discussed. Next, you look at the membranous septum, and also you look at the whether the valve is bicuspid or tricuspid. I'm not going to go into detail, but one important parameter which we need to know: what type of bicuspid valve is it, type 0, type 1, type 2, and then we need to go ahead and do further assessments. whether the height of left coronary artery, whether we can fracture the raphe or not, which side the valve will sit, and what is the chances of paravalvular leak. This is a picture which just shows that the annulus has multiple shapes and it is not a full circle. And this is the how we can derive the annular plane by using a CT scan. So you see, we need to identify the nadir of all three cusps: left coronary cusp, the non-coronary cusp, and right coronary cusp. And then we need to identify a plane which brings all these three cusps into a straight line, because that is what is the annulus plane on the fluoroscopy. And then we need to measure the perimeter for a self-expanding valve, area for a balloon expandable valve. And you can look at the third picture, how the annulus has a short axis and a long axis. The importance of short axis is we choose a pre-dilatation balloon based on the short axis so that we make enough space that the valve can go in. And our post-dilatation does not exceed the average diameter of the short and long axis. 3D multiplanar reconstruction is must to understand the CT scan and in order to verify the aortic annulus. Next thing is, once we have assessed the annulus size, the second most important thing is assessment of calcium. So the calcium on the leaflet is good for us. Calcium at the annulus base, calcium projecting into the LV outflow tract and calcium at the sinotubular junction is bad. The next thing is, now we also measure the length of the membranous septum. So this is very important. How do we minimize our pacemaker rate in patients who undergo transcatheter valve replacement? So this is the anatomy. The conduction fiber, they go 5 millimeter below the annular plane, provided the length of membranous septum is 5 millimeter. That means they will go beneath the membranous septum. So if our valve is deeper than 5 millimeter, there is a high chance of conduction system abnormality. And if a patient has a baseline right bundle branch block, we can knock out the left bundle and there is a high chance that patient will develop complete heart block. But if the membrane septum length is also small, something like 2 or 3 millimeter, even a higher implant can cause heart block. Aortomitral continuity, very important for us to understand. As it was pointed out by Dr. Burkle, if the valve is lower than the AML hinge point, the valve is deep. This is an example of calcification extending into the LV outflow tract, and this is the TAVR landing zone. So the operator needs to know how far is the calcium, what is the thickness of the calcium, what is the diameter from inside the calcium to the other part, and based on that, he has to choose a proper valve so that the outcome is good and it is safe. Sinus of Valsalva diameter. What is the importance of sinus of Valsalva diameter? So what is the mechanism of coronary occlusion? The coronary occlusion happens from the native leaflets. It's not by the TAVR valve. So when the TAVR valve goes and sits at the annulus, it displaces the native leaflets and they can go up and occlude the coronary arteries if the sinus of Valsalva are shallow and coronary height is low. So it's very important for us to understand these dimensions. And this is how you also measure the sinus of Valsalva height. As I said, the coronary occlusion is an interaction between the sinus of Valsalva diameter, sinus of Valsalva height, coronary height, and the size of the valve which is being implanted in the patient. Coronary arteries. So a safe cutoff is 12 millimeter. Anything about 12 millimeter, you are safe, but even a coronary occlusion can happen at a coronary height which is more than 12 mm, especially in a bicuspid valve. If the coronaries are shallow, sinus of Valsalva diameter is shallow and one of the leaflet is longer than using a balloon assisted technique, and you know that sometimes the procedure can be challenging in a horizontal aorta. Peripheral vessels. This is very, very important. As I said, majority of time we would like to do our procedures from the femoral approach by using a percutaneous axis. If you are well experienced with it, because it makes a lot of difference in patients' recovery and long-term outcome. So what are we looking at the peripheral anatomy? We are looking at the diameter. So if the dimension of the vessel is 1 or 1.05 times the dimension of the outer diameter of the sheath, which is required when the valve goes through it, you can safely do a TF TAVR. So we are looking at the tortuosity and calcification. So what is the definition of severe tortuosity? More than 290-degree bends is called severe tortuosity, and it is the calcium and the tortuosity which can create a problem. The second thing, you look at the level of bifurcation of the common femoral artery. for a percutaneous access to be successful, the puncture has to be in the anterior wall of common femoral artery. If the puncture is not in the common femoral artery, then probably the percutaneous approach will not work. But this is how the CT scan helps. You can get all the views and the dimensions of common iliac, external iliac, and common femoral artery, and you can choose a better way to take the access. This is a 3D picture which shows the tortuosity, because if you have more than 290-degree bends, it is called severe tortuosity. CT scan protocol, this is standard. I can just pause it and explain it. You need to have a ECG gated CT scan for the annulus and a non-ECG gated CT scan for the aortogram. And it should include your up till the bifurcation of the common femoral artery. So sometimes what I tell to my radiologist, if there's a confusion, I ask them to do a CT coronary angiogram. But in the CT coronary angiogram, you always use a diastolic phase. Here you use a systolic phase, which is something like 30%, 35%, or 40% of RR interval. And the rest of the aortogram is standard, which you have to cover, the radiologist has to cover till the live CT scan analysis, how you do a CT scan assessment using a 3D multiplanar reconstruction. So the annulus is always measured during systole. And the reason is the dimension of the annulus is more during systole and not during diastole. The only time you can use diastolic measurements is if a patient has septal hypertrophy. Then only a diastolic measurement can be helpful, because during systole, that septum which is hypertrophied will pull the annulus and shorten it. Otherwise, it is a systolic phase which you have to measure. These are all CT scan protocols where you can measure calcium, very important, mild, moderate, severe. Look at the distribution of calcium. If you look at the first picture, there is a small speck of calcium at the annulus. We can easily do either of the valves. Second one, moderate calcium. You see the calcium has a lobulated appearance at the level of annulus and it projects into the LVOT. Severe calcium, look at the calcium which extend into the LVOT and on the leaflet. If you look at the third one, severe calcium, that much of calcium increases the risk of LVOT rupture, increases the risk of complete heart block, increases the risk of VSR, ventricular septal rupture. It can also create a Garbodi defect from LV to RA. If you look at the anatomy of membranous septum, if you have a high membranous septum defect, you can have a shunt from LV to RA. So very careful when a patient has this type of calcium. Coronary height, which we already discussed, this is standard. But bicuspid anatomy, very important. I'm just going to not going to go into detail, but this slide which shows you that when we do a bicuspid aortic valve, we need to look into the CT scan very carefully. We need to identify what type 0, type 1, or type 2 bicuspid. And because we can have a discussion when we discuss among ourselves, but this is a big topic in altogether. For bicuspids, yes. So how does a TAVR valve stay in place? This is very important. Surgeon will suture the valve. What do we do? So the TAVR valve stays in place just by its sheer radial strength. That means the valve has to be oversized to the annulus for it to stay in place. So what is the oversizing? It is the difference between the measurement of the valve minus measurement of the annulus divided by measurement of the annulus. So what are the predictors of annulus rupture? Female sex, valve size more than 20%, history of radiation therapy to the chest, moderate to severe calcium below the non-coronary cusp, and extent of calcium within 2 millimeters, sorry about that, 2 millimeter of the annulus plane. If the calcium is within 2 millimeter of the annulus plane, there is a high chance of annular rupture. What does it mean? If the calcium is below 2 millimeter of the annulus plane, probably that is not your landing zone. So that calcium will not interact. But if you are within 2 millimeter of annulus plane, this can cause annulus rupture. This is the new measurement which we do, length of membranous septum. Now, sometimes in some of the TAVIs, even if I do a very high deployment, say 0 position, still a patient can have a complete heart block. And the reason is the membranous septum is very small. So the conduction fiber, they go beneath the lower end of the membranous septum. If it is very small, there is a high chance of complete heart block. This was already highlighted by Dr. Burkle that calcium score for the valve can be used to assess a low flow, low gradient normal EFAS. So if the calcium score is less than 1600, that means that patient is unlikely to have severe calcium. For males and for females, it is less than 800. Well, vessels calcification, we already discussed 40, moderate, mild, moderate, severe. I want to stress on severe because if you can appreciate that, that is most important. If you have a circumferential calcium at the bend, that is called severe calcium, and you cannot expand that vessel even by 1 millimeter. Next is CT scan for a valve in valve case. What is the additional thing which we are looking on a CT scan for a valve in valve case, where we look at the size of the tissue valve which was implanted and the coronary height. And then we also need to know what type of valve was implanted, and the leaflets are on the outside or on the inside. And then whether the valve can be fractured or not. Post procedure, we look at valve thrombosis, infective endocarditis, structural degeneration, HALT, and HAM. This was already highlighted by Dr. Burkley. So what is HALT? Hypoattenuated leaflet thickening, HAM, hypotension affecting motion. Now, if you have a patient whom you are following up, either surgical valve or a TAVR valve, and it's a tissue valve. So at 1 year, 2 years, the gradients go up. Put that patient on anticoagulation for 3 months, maintain an INR of 2 to 3. Majority of time, it is the bioprosthetic valve thrombosis which has happened. If it is a regurgitant type of failure and there is a central regurgitation, there is a high chance that and how the leaflet motion is affected. This is again a CT scan assessment where we can see. So if you look at the picture, how the base of leaflet has thickened, and that is because there is a bioprosthetic valve thrombosis, and this thing dissolves. And this is the picture of my transcatheter double valve replacement, which I did after 6 months follow-up. And here you can also see how the patients and the valve interact post any sort of complicated procedure. So imaging is very important post TAVR, and that is because you need to identify whether a patient has bioprosthetic leaflet thrombosis, paravalvular leak, or a failure of the leaf. Can you do a TAVR in a patient who has CKD? So look at this picture, patient history. 65-year-old lady, prior renal transplant on immunosuppressants, presented with recurrent heart failure, creatinine of 2.2, transplanted kidney with compromised renal function test. So do you do a CT with contrast or no contrast and role of 3D TE? So in such a scenario, this is the only patient in which I did not do a contrast CT scan because it's a precious kidney, transplanted kidney, creatinine of 2.2, but I still went ahead and did a non-contrast CT scan. You know why? The non-contrast CT scan will give you an idea of the annulus and LVOT depending on the calcium itself. You need not inject the contrast, but do an ECG gated non-contrast CT scan and then do a 3D TE to assess. This is the same 3D TE pictures from this patient and a valve being implanted without any contrast being administered and an echo. But the valve which you select for such a patient is a self-expanding valve. A balloon expandable valve can also be implanted, but for a balloon expandable valve, you need to have a precise annular plane, which you can obtain by putting 3 pigtails in position. So proper planning is half the work done in all our TAVR patients. So what I'm going to do is I'll just go ahead and present the second presentation, which is on TAVR proper, and I'll keep it very short, and then we can have a discussion because this will involve a lot of interest, especially among all the TAVR operators. And it will also help us to understand how to select a TAVR valve. So we're going to understand about the valve and the steps of doing a TAVR. First is crossing the valve. So let us look at this CT scan, 82-year-old lady with severe aortic stenosis for TAVR. So once we take our access, the first thing we do is we cross the valve. So how do we cross the valve? You can use an AL1, AL2, AR1, AR2. And you use a straight tip wire. Straight wire could be a straight tip thermo wire, a straight tip Teflon wire, depending on the operator's choice. But here, I always prefer to use a straight tip thermo wire. And then after multiple attempts, we are not able to cross the valve antegradally. And Dr. Burkle was part of this procedure almost for 45 minutes. So if you're not able to cross the valve for 45 minutes, there has to be a reason. And then you go ahead and look at the CT scan. And the reason why we were not able to cross this valve is because of this anatomy. So you see this patient had a heavily calcified valve and the orifice is eccentric. You see this? So I need some type of a catheter which goes like this and the tip faces into this eccentric orifice, and then only I can cross. But such type of catheter is very difficult. We tried all the catheters. What do you do next? Do you abandon this procedure? So the next step was we did a transseptal puncture, and this is the TE probe which goes in, cross the valve antegradally from LA, LV, and aorta, because antegradally the wire will cross very smoothly because you are going the direction of the flow, snared the wire, then did a valve take and then to the pigtail. So the valve deployment is not through the transeptal, but the valve deployment is standard. And this is how the snare looks like. You see, you snare the wire, and on the wire, look at the advancement of the pigtail. See, and this is exactly this is how the pigtail is entering, as how I had showed in the diagram, where the opening is so eccentric and the pigtail enters. Once the pigtail is there, then this is standard. You do a pre-dilatation and evolute our self-expanding valve was deployed. So the first step which I showed here was crossing the valve with the wire. So you cross the valve with AR2, AL1, AL2, multi-purpose straight tip wires. But if it does not work, the best way to cross the valve is do a transseptal puncture, cross and snare. Now the second step is valve is not crossing. And then you need to understand why valve is not crossing. So in this particular patient, the wire goes, but the valve does not go. So if you can see, the reason why the valve does not crosses is because of a bicuspid anatomy and very eccentric orifice. So you see what happens as you try to push the valve in, the valve will not cross. Again, you need to understand the mechanism why the valve is not crossing, and the reason why this patient's valve was not crossing is because the valve was not coaxial to the opening. The opening was somewhere else and the valve was trying to cross somewhere else, and because of a very horizontal aorta, it did not cross. So the use of a snare, how does it help? You use a snare, cross through the snare, and some of the people were there in one case which I did in HN using a snare. You pull the snare valve and make it coaxial to the opening, and this is how a bicuspid valve is implanted in a bicuspid anatomy. So then in such situations, you need to understand why the valve is not crossing and why what is the mechanism, and then we need to tackle that particular mechanism. Number one, this patient, 84-year-old patient, severe aortic stenosis, severe LV dysfunction, NYHA class 3, COPD, diabetes, prior PCI, normal renal function. And this is the echo picture. You can see the aortic valve orifice. And this is the EKG. You see a right bundle branch block, LAHB, first degree heart block. So this is going to be important for all of us to understand the valve selection. And this is the coronary anatomy. And this will also help us to understand how do we tackle patients with severe CAD. So you see the left coronary artery. We have some very expert coronary interventions interventionalists in our panel, and we can discuss this also later on, how to tackle CAD in a TAVR patient. So you see that left main disease, 100% ISR of the circumflex stent, disease in mid-LAD, disease in the diagonal, and look at the right coronary artery. Diffuse disease, but this patient is 84-year-old, severe LV dysfunction, severe AS. So challenges, severe CAD, severe AS with severe LV dysfunction. What do you do? Concomitant PCI plus TAVR or only PCI? What is the LV hemodynamic support? So when you're selecting a valve, what are the thought process? You want to avoid a PVL in this patient. The reason is, if a patient has severe AS, and severe LV dysfunction, and you leave this patient develops a left bundle branch block, again, low EF, there will be challenges in the EF improvement. And if you give this patient a RV pacing or a septal pacing, will again be a challenge in patient who had low EF. And then how do you select your valve size? This is a CT scan assessment, 26 versus 21, 29 left coronary arteries, 13 millimeter RCAs, 18 millimeter. And for the complexity, it is a horizontal valve. So I decided to do a PCI plus TAVR in the same setting, 14 French axis, 6 French left coronary, 6 French right common femoral vein. And the plan was to do a BAV first, then a PCI, and then a TAVR. What does a BAV do? BAV will optimize the hemodynamics in such patient. How much CAD to revascularize? To a patient who's left main LED, and I would revascularize that alone, then do a TAVR, and then call this patient for a follow-up for the remaining CAD. Any hemodynamic compromise, I'm ready for the valve deployment. That's why I started this procedure with a 14 French sheath, because in an aortic stenosis, if your patient become unstable, the way to stabilize is you fix the AS. So if you are doing a TAVR and your patient becomes unstable, don't wait for the patient to become stable and then put a valve. No, you go ahead and put a valve, and that's how the patient will become stable. Because in severe AS, even CPR is ineffective. So this is a balloon valvuloplasty followed by a cutting balloon PTCA and just a left main PCI using a DES. And the valve which I selected in this patient was a SAPIEN 329 millimeter valve, so that I can avoid paravalvular leak, I can avoid a pacemaker in this patient, and then implanted this valve as high as possible under rapid pacing. So this was a challenge of rapid pacing in such a patient, which we can discuss. And once the valve is positioned correctly, we would pace at 180, slow deployment, go ahead and inflate. And this patient, this is how the valve looks like. You see the horizontal anatomy, and just one whiff of contrast, almost negligible paravalvular leak. This patient has actually, and this is the post-procedure, echo mean gradient is 8. And this patient has actually completed almost 1 year follow-up, and he does not want any treatment for his RCA. Now look at this 76-year-old surgeon, previous history of biobental using a 23 millimeter Magna valve, left coronary 9 mm, height of the BSA of this patient is 1.5 centimeters square. How do you select a valve in valve, SAPIEN versus Evolute? So a SAPIEN will give easy access to the coronaries, disadvantage is higher gradient. Evolute will give less gradient, disadvantage is difficult coronary access. So the important thing is you look at the BSA. If a patient is obese and body surface area is too high, you need to give a better effective orifice area. If this patient has a 19 millimeter valve, the only valve which you can put is a self-expanding supraannular valve. But because this patient had a baseline 23 millimeter valve, a balloon expandable valve helped us to give a coronary protection, and a SAPIEN was used. But if you look at this patient who is 84-year-old lady, has a 19 millimeter valve, but weight is 100 kilogram. For such patients, you need to use a self-expanding valve, because that will give less but difficult coronary access in such patients. So in this particular patient, a self-expanding valve was used, and this is how a valve is done in a valve-in-valve position. You implant a very high implantation so that you get better effective orifice area, do a post-dilatation to minimize the patient process mismatch, and this is the post-procedure where there is no paravalvular leak. 78-year-old female, double valve replacement in the past, 19 mm trifecta in aortic, 27 in mitral position, 7 years post-surgery, degeneration, and severe mitral regurgitation. So again, this will help us in valve selection. So you look at the degenerated aortic and mitral valve. So for aortic, because it's a 19 millimeter valve, you need to put the self-expanding valve. And for mitral, because it's a valve-in-valve, you need to use a balloon expandable valve. But the idea with the discussion is which one should be replaced first, aortic or mitral? And if we decided to do aortic first and used Evolute R and SAPIEN 3 for mitral. So this is the aortogram, and you can see how the right coronary is so low. And then you protect the right coronary with a Judkins catheter, and then go ahead and do a TAVR Evolute R. And the reason why coronary is being protected is because the trifecta valve has leaflets on the outside. There is a high chance of coronary occlusion. Once that is done, The stent was not placed in, was not required because the coronary was still flowing. You do a post dilatation, minimize your hemodynamics, and then once that is placed, we do a septal puncture, and through the septum, we would go ahead and cross the mitral valve, and a sapien was implanted in the mitral valve, a 26 millimeter sapien. These are the certain steps which we can discuss. There's a balloon atrial septostomy, and a 26 millimeter sapien is being implanted in the right position. But this particular patient, I have kept her on acetylene because she was a transcatheter double valve replacement, and this is how the valve looked like. But this patient has normal gradients. I thought I'll share my, I have my own data of single center, which I've done in Jaipur, almost 100 patients. The average age is 72.93. This is the data of 105 patients, single operator, single center experience. The mean age is 72.93. Female is 36%. Male is 64%. Body surface area 1.76. Majority of patients are symptomatic. But bicuspid anatomy was seen in 31% of patients. And this is what we are seeing in Indian practice. Almost 1/3 of patients are bicuspid. These are the procedural characteristics. Conscious sedation was used in 104 patients. Mean fluoroscopy time was 24 minutes. Mean procedure time was 61 minutes. Mean contrast was 82 ml. Pre-dilatation was done in 54% of patients. All patients underwent percutaneous transfemoral TAVR. Surgical cut down was used in 0 patients. Procedural success was 104, 99%. Intra-procedural death was 0. Annulus rupture was 0. Aortic dissection was 0. Valve size 20 mm valve was used in 4%, 21.5 in 2%, 23 in 33%, 24.5 in 2.8, 26 in 28.5, 27.5 in 0.9, 29 in 20.9, and 31 and 34 in 5.7%. 2 patients had femoral complications requiring stenting and ballooning. Procedural outcome, all-cause mortality was 1 patient, 0.9%. Procedural mortality was 0. Stroke was seen in 2 patients. Even at 30 days, remained in 2 patients. 1 patient had a disabling stroke. 1 patient had a TIA. Pacemaker implantation was only in 5.7% of patients. Severe paravalvular leak was in 1 patient. Moderate paravalvular leak in 1.9%. Mild paravalvular leak in 0.8%, trivial in 6.6%, and no PVL was seen in 87.6% of patients. Average ICU stay was 26.4 hours. Average hospital stay was 5.4 days. Average post-procedure mean gradient was 8.4. Average post-procedure peak gradient was 15.3. Acute kidney injury was seen in 2 patients, and no patient had infective endocarditis or valve thrombosis at 30-day follow-up. This is again distribution of the paravalvular leak. No PVL was seen in 87.6% of patients. It was seen in 6.6 and 2.8% of patients. This is the outcome which I have compared with the standard trials, which is Partner 3, Evolute R, and Notion. If you look at the average STS score of the Partner 3 was 1.9, Evolute R 1.9, 2.9 for the Notion trial, and 3.9 for our cohort. Pacemaker implantation rate 6.6 for Partner 3, 17 for Evolute R low risk trial, 34 for Notion. Here 5.7%, mortality 0.9%, stroke 0.6 for Partner, 3.4 for Evolute, 1.4 for Notion. Here 1.8%. Mild PVL was seen in 2.8%, which was 39.6 in Partner 3, 37.6. And in Notion, it was 61. Notion had self-expanding valve, which was used in all the trial, and moderate to severe PVL was 0.8 in Partner, 3.5 in Evolute, 15 in Notion, and 1.9% in my data. Thank you very much for your kind attention.
Thank you, Dr. Ravindra. I think Anandra and Dr. Kane, we both will take the question answer session. I think we have first questions from yourself, and then I think some questions will come from the audience. Actually, we can take them also. I think Kane was to start something. I think he had some questions with him.
Can you hear me?
Yes.
Ravindra, meanwhile, I'll ask you. See, even in spite of the best technology, this paravalvular leak and the pacemaker implantation still remain the challenges. How do you minimize that? Actually, now you've been doing all the technological thing. Still 5% of pacemaker. and paravalvular leak of 2 to 3%. These are major challenges at the procedure.
So I fully agree with you, sir. These are the two major challenges, but we have come a long way. The initial pacemaker rate was almost 30 to 35%. Now we have come down to 5.6%. But I would like to compare that data with the surgical AVR. So what is happening is the surgical AVR, which is being reported in Indian patients, is in younger patients. So I would like to ask the pacemaker rate of surgical AVR in the same patient cohort. So if you look at the partner trial data, where it was randomized to surgical aortic valve replacement, the pacemaker rate was almost 3 to 4%. Similar pacemaker rate. There was no statistical significant difference. But what I would say, as I said, as we tailor the valve to a patient's anatomy, and the way we tailor that is by understanding the membrane septum depth and trying to implant the valve as high as possible, we can minimize the pacemaker rate even further. And the paravalvular leaks, a paravalvular leak now again it has come down because of the device iteration, where there is a skirt on the outside and prevents the paravalvular leak. And the second way is we are able to size the valve better. Earlier, what was happening is patients were going home on mild paravalvular leak because there was a study which showed that mild paravalvular leak does not affect the long-term outcome. But that data was based only on the high-risk trial. Yes, it does not affect the long-term data if your patient is 85-year-old and STS is 10. But a mild PVL affects the long-term outcome if your patient is young and the STS score is 2 and 4. So now in the current scenario, if my patient leaves the cath lab, he needs to leave the cath lab with trivial or no PVL at all.
Ravind, the other thing, how do you convince asymptomatic AS person to go for a procedure? That's a major challenge for us.
I don't convince.
Kirti will be the best person, I think, will how to convince an asymptomatic AS patient for a procedure of such an expensive procedure. How do you convince them? Kirti will be a better person, I think.
Yes. Number one, sir, I would like certain criteria is in my mind for an asymptomatic patient. If the mean gradient is more than 60, velocity is more than 5, EF has started coming down, I am pretty sure that patient is hiding the symptoms. So that is what we call it as very severe aortic stenosis or critical aortic stenosis. I would go ahead and offer him aortic valve replacement. But if patient is truly asymptomatic, I would follow him every 6 months until there is an onset of symptoms or the mean gradient goes above 60, peak gradient goes above 100, velocity above 5, and aortic valve orifice area less than 0.4.
Our patients have a habit of hiding the symptom. That's a major thing.
Yes.
That's the one thing. Dr. Kane, sir, actually, and Dr. Anand, what you have?
Yes. Dr. Kane, you want to begin?
Kane has something.
I can start if you want one question.
Yeah, please start. Please start.
I want to ask all three, Dr. Kirti, Dr. Haresh, and Dr. Ravinder Singh, whoever wants to take this question, can you throw some light on hemodynamic data of S3 and evolutar? So hemodynamic
yes, I
data.
can. I can share that.
Because in one of the slides you said with this S3 is high gradients, so
yes.
So let us understand this hemodynamic data among this.
So that's a very, very important question. So what is a gradient? Gradient is an interaction between the orifice area and the flow. So if my orifice area is small and my flow is small, I will not have a gradient. But if my orifice area is small, and my flow is large, I will have a gradient. And that is called patient processes mismatch. So a 20 millimeter valve, when implanted in a lean and thin patient, will not give any gradients. But a 20 millimeter valve, when implanted in a patient who is obese and higher body surface area, will give a gradient. And the reason is, if you are obese, the cardiac output and stroke volume is more. If you are physically very active, your cardiac output is more. If you are putting a valve inside a smaller valve, again, the gradients will be higher. So as I said, it's not that the 20 mm valve is giving a higher gradient. A 20 mm valve inside an obese patient is giving a higher gradients. Number one. Number two, now if you look at the orifice area of a self-expanding supraannular valve is more than the orifice area of an annular valve.
Why is that?
In an annular valve, the leaflets are at the level of annulus.
Yes.
Supraannular valve, the leaflets are not at the level of annulus, but they are hanging above. So there is a study which is being publicized. If the annulus is very small, it is a self-expanding supraannular valve implanted at the correct depth. I have to point out that. If you are deep, you become annular. Implant at the correct depth gives better hemodynamics compared to a balloon expandable valve. But for larger annulus, a balloon expandable valve is better than a self-expanding valve, because if you implant a larger self-expanding valve, there is a high chance of PVL, high chance of complete heart block compared to a balloon expandable valve, which is 29 millimeter. So 29 versus 34 evolute, a 29 is better. But a 20 sapien versus a 23 evolute, a 23 is better.
Kirti, Ravinder, I would actually, I think we have enough time. I hope Kirti is
Yes.
I'm right here. Yeah.
quick, because the talk is important for us, may not be for you all. But let's start.
No. I think.
Let us start from some basic. I just wanted to ask you first about anesthesia. You said you do 95%. You said 104 patients you did conscious sedation. So
Yes.
how do you decide in which patients would you give general anesthesia?
So now at present, what I do is when the patient walks into the hospital, I would ask my cardiac anesthetist to evaluate the patient. I would give him a phone call and I would tell him I would like to do conscious sedation, but I will leave that call on him. So it's very important that a patient undergoes a full pre-anesthetic checkup. Even I did not share the whole conscious sedation protocol, but I can share on the email of all the attendees. I would ask my anesthetist to do a full PAC one day before the procedure. So next day, what all we do is we would use something called a EMLA solution. So what is EMLA? Is eutectic mixture of local anesthetic. It is a mixture of prilocaine and bupivacaine and lignocaine. You just apply it on the neck, both the radials and both the groins, 2 hours prior to the procedure. And when the patient comes into the cath lab, if a patient has COPD, we don't even give any sort of surgery for all the patients. We use something called a BIS monitor for all the patients. We use a nasal CPAP for almost all the patients. Now, if we have to use a sedation, we use something called dexmedetomidine infusion. So a lot of people are scared of dexmed because it can cause hemodynamic, up and down. But that only happens if you use a dexmed bolus. But if you use a dexmed infusion, it is very smooth. Next, we would have neckline for all the patients. We would have radial line for all the patients. So this part goes to my anesthetist who would do and the cerebral oximetry is like real time. It is happening real time. But we would do, and one day before the procedure, all my patients would be doing incentive spirometry and chest physiotherapy, morning, afternoon, and evening. And then we take these patients for a conscious sedation TAVR.
So do you have to convert them to GA? And how do you do a TE in with conscious sedation? Can you do TE or you don't do TE?
We don't do TEs at all. So if you look at the current indication, or maybe the procedural steps, I would not go into indication, but at no point you are being guided by TEE if you are doing a TAVR. That is aortic valve replacement. It is fully fluoroscopic guided procedure. The only role of TEE is to assess the mechanism of paravalvular leak, if it is there any, not even to quantify. I want to quantify my paravalvular leak by 2 things. One is an aortogram. Second one is AR index. So if these two show me severe paravalvular leak, I would go ahead and fix it rather than trying to do a TE and understanding the mechanism. But TE role is to understand the mechanism of paravalvular leak only, nothing else. I would do a pre-procedure TE if I have to size the valve, as I showed in that example, where I had to do a 3D TE to size the annulus because that was a zero contrast TAVR. Otherwise, no.
Yeah, Kirti, what is your, how much you use conscious sedation, how much GA?
So we
Same.
so we have been doing towers and to do it at Hiranandani, and I think Ravindra, you were there for one of those, right? When we did a medal. So at Hiranandani, as a policy, Ganesh had adopted that he is going to do general anesthesia for all these patients, but we are now slowly cajoling him to get out that space and trying to do the conscious sedation bit. But some of the patients that we've accepted lately have been so sick that we've decided that we want a not a moving target, and therefore we decided on general anesthesia. Now, at Bridge County Hospital, we initially started with the general anesthesia and with a TE, but we quickly, after the first three cases, we moved on and it's all conscious sedation. In fact, one of our patients had required a laryngeal mask. Otherwise, yes, we just do a nasal mask, and I think we're okay with that. Ravindra, my question to you is you've shown a very eloquent series. And I know that you're known for taking up some of those very challenging cases. My question to you is these come with a lot of peripheral vascular problems as well. A large part of your experience also comes from the Merrill valve, right? And so, with that valve, have you had to resort to alternative accesses, especially because of, I mean, now we have the new sheets, but in the prior time, have you had alternative accesses just because you thought that your femoral and iliac was too small with too much of calcium and too much of angulation, so you had to resort to another access? And what is your experience with that?
So I just shared my own single center data. In that, the Merrill is accounting for 25 valves, Sapien is around 37, and Evolute R is around similar 30 to 33. Out of the Merrill 25 cases, the valves which were done with big sheet were just 8 when we were part of the trial. And in that trial, we did a meticulous selection that patients above 8 mm groin, a vessel size of above 8 mm, were only enrolled in my center. There were a lot of other places where they tried to do in smaller groin also, but we selected just 8 mm and above. Once the Python sheet came in place, which was a 14 French, we did not have a problem. But to answer your specific question, man trial, it was a 22 French sheet, and one of the inclusion criteria was a TF approach only. And we did a rigorous selection for our center. Vessel above 8 mm only were selected, not below 8
Jaipur data. No, okay.
mm. No.
Okay.
That's very encouraging.
Yeah.
Because,
But I don't say that. Outside Jaipur, I've done a lot of non-TF towers as well, but it depends. I would just say we were lucky enough because in the trial, I was pretty sure, as I said, a non-TF has a poor outcome. If you do a
what
thoracotomy
is
in your
the
first.
So we share just to share, um, and our in that small experience, we found that at least there were three cases which had very challenging femoral accesses. I mean, we're looking at the belly 6 mm with at least 190-degree bend, calcium on the opposite side. Very the kind that you expect that you will have a rupture. There was, I guess, you were in the lab when we struggled with one of those to push it in. I mean, was it the same one or was it the one that we did after you were there when you were present? But you remember the challenges we faced. I mean, we, even in our small experience, we faced a fair challenge. So what is it that you have adopted different where it seems to be going very smooth? Or is it that just the better ones are coming to you?
Yeah, no, I think the second one is also, I can say all have big size, adequate size femoral vessels. But one thing which I have done is
North Indians, right? And so
yeah. So if a patient has 6 mm vessel, and I'm putting a valve which is bigger than 26 millimeter in size, again, as I said, I also tailor my valve to a patient. There are so many patients who would have come for a Sapien, but if the vessel is 5.5, I would go ahead and put an Evolute in them.
Right.
So as I said, I would tailor my valve to the patient's femoral anatomy, because for an Evolute, you can go even to a 5 mm vessel if it is non-calcified, sheathless. So as I said, I see the CT scan and then I see which valve can go through a TF approach. And that is how I would counsel my patient also. So 6 mm, a 5 mm vessel, I would do a evolute, and which I've done in majority patients. And they would come for a different valve, but I would try to convince them. So as I say, no, even in our practice, if we tailor a patient's TAVI to a TF approach, it makes a lot of difference. I don't know how you feel about it, Dr. Kirti.
Yeah.
Harish, what is your experience?
Yeah, so we started with a GA because we started new in Mumbai. We started a couple of cases with GA and TE. And as Ravindra said, we quickly realized TE was not contributing. And fortunately, we had a good cardiac anesthetist with us and who would see the patient one day before. And then since then, we've done about 18 cases after that, and all have been conscious sedation, and we've never had to switch anybody to general anesthesia. The important thing that Ravindra was saying, I mean, it's very, we know that TAVR works. It works in almost all cases nowadays. I had a question for him regarding the bicuspid anatomy, because that's a very important TAVR which you're going to face in India, because you get more bicuspids and we get younger patients in India. So have you changed your sizing strategies, or you are still sizing as per annulus?
So so as I said, 31% of my cases is bicuspid, and I'm writing it up because I have almost 2/3 now, which is US FDA approved, almost 67 of Sapien plus Evolute R, and similar 1/3 kind of my valve. Surprisingly, all three valves are working fine in a bicuspid anatomy, provided you have sized your valve properly. I size based on annulus. I don't do 5 mm, 8 mm, 3 mm. But what I try to understand is what is the type of bicuspid. If it is a type 0 bicuspid, I would size based on the annulus. Now, if it is a type 1 or type 2 bicuspid and the raphe is heavily calcified, I know that I cannot break that raphe, and my valve will be sitting only on one side of the annulus. In that particular anatomy, so if I have to size, again, I will size based on the annulus, but I would not like to go up till 12% or 15% oversize. I would just like to keep it at 0% or something like 2 to 3
inner edge of the inner end of your prosthesis. You cannot take the native alveoli. That is one thing. And secondly, what about the paradoxical low flow, low grade aortic stenosis? Now, necessarily these patients have patient prosthetic mismatch. And I think most of these, if you measure on the echo, you will get a diameter of the alveoli something like say 17 or 18 millimeters, which is definitely very low. So these patients definitely don't have a circular alveoli. So I think there you would definitely use the CT for the alveoli area, and that you would use as a hybrid equation, that the numerator you will use the cross-sectional area from the CT alveoli and use the velocity time integral and get the aortic wall area. Now, what type of wall to choose, I think that is the interventional cardiologist will decide. But let me reiterate that these patients are the most challenging ones, the paradoxical low flow low grade AS, because many of them are symptomatic because of their comorbidities and not because of their severe aortic stenosis. So it's a very challenging thing. I think a lot of clinical skills needed to decide whether the aortic wall is the root cause of symptoms or not in this particular group of patients.
One question to Ravindra.
I have a question for you. Question for Dr. Burkle. Can I ask?
Yeah.
So if you see a patient of severe AS with severe LV dysfunction, and the dobutamine stress echo is not up to your parameters, do you think TAVI is still indicated in that scenario subset of patients? And if so, why?
Yeah, truly, because you are talking about the patients who have got a severe aortic stenosis, severe LV dysfunction, and no contractile reserve. Because as you said on dobutamine, you can't increase the stroke volume. So these are the ones which are the contractile reserve negative, classical low flow, low gradient, severe aortic stenosis. Actually, TAV, they are the best patient to go for TAVI, because as per the TAVI registry, actually these patients, the outcome was not dependent upon their contractile reserve on dobutamine. Whether they had a contractile reserve or no contractile reserve, the improvement in ejection fraction or the survival was not dependent upon the contractile reserve. So only thing is I would like to make sure that this is a severe AS by doing a CT calcium score. If it is that also is in that range of 2000 for a male, then I think this patient is truly for TAVR. I think there is no role of low dose dobutamine in
Then
this.
do you think we can skip low dose dobutamine stress echo and straightforward
Go for
go
calcium.
towards calcium scoring?
True, we can definitely do for these patients who don't have a contractile reserve. That is what I'm saying. That if the TAVR unload trial also comes positive, then you will not need a low dose dobutamine, because now that's the only subset where we still don't have answer. That is the patients who have a contractile reserve but who have a moderate aortic stenosis. That means those are pseudo severe aortic stenosis. So that group is still under investigation. So probably the low dose dobutamine you need only to catch that group of patients where you would still conserve them. But once the TAVR unload tells you that it works even in patients with moderate AS and LV dysfunction, then we really don't need the dobutamine, low dose dobutamine test.
Yeah, I agree. But the other thing which the low dose dobutamine stress echo does is it gives you confidence as a doctor, or as an operator, or as a physician who's taking that. At least the patient is going to benefit from TAVR, or any aortic valve replacement for that reason. Yeah. And
Harish, I had a question. You said that you measure at annulus in bicuspid aortic valve. Some people say they measure at 3 millimeter, 5 millimeter.
Okay.
So how does it make a difference? How can the result be same if you measure at different levels?
I'll explain this to you because it depends on whether you have an inverted funnel or a funnel which is going down, where the annulus is above the annulus is bigger or above the annulus is smaller. So now they have a couple of data which says that you do balloon sizing, wherein they take a balloon and measure the waist at which the waist comes. So they measure that plus the annulus, divide by 2 and size it. So it generally a size smaller. They say that a size smaller is better because it reduces the risk of pop out. And if you're using a balloon expandable, reduces the risk of rupture if there's a lot of calcium. And the balloon also tells you that this size will not cause PVL because they also check the AR at the same time. So this is what many of them are doing. But in probably 2/3 of them, the annular size and this size will turn out to be the same. So as Ravindra said, they still will go by annular size. But some patients, yes. Remember the case that Dr. Anmol put up just 3-4 days back?
Yeah.
He would have done better with a one size smaller valve. Because you saw the constraint of the frame that the evolute R he had.
And that patient, finally, what I realized or I understood was that balloon expandable would have been a better choice in that patient.
Yes, because as he said, in a 34 bicuspid, a 29 balloon would have been much better. But in case you had put a self-expanding in that, I would have put a 29 and post-dilated would have given you a better frame and less chance of pop out than a 34, which is going to remain constrained, which can lead to early, probably theoretical degeneration of the leaflets.
It can. So the largest data comes from France on a sizing of bicuspid anatomy. I think it's on 1,000 patients, and they did all these permutation combinations, and they found it finally it is the annulus which is is okay. So there's no standard guidelines, but as I said, no, you cannot. As I said, no, it is an annular complex. You just can't look at the annulus. You look at the LVOT, you look at the annular plane, you look at the. So what happens, sir? The question, to be very precise, Dr. Kani, your question is the coaptation plane in a bicuspid valve can be higher than the annular level, and that is because the leaflets they're going to be coapting something like this, and that is how the sealing zone. So why we are interested in annulus? When you put the valve in place, what is the sealing zone to prevent the paravalvular leak? Number one. Number two, to anchor the valve. In a bicuspid anatomy, the sealing zone can be higher than the annulus. And that's why a higher anatomy or a smaller valve can work very well. But this is proven. 34 versus 29 balloon expandable is better than 34 self-expandable anytime because it's very difficult to control a 34 valve.
And as Ravindra said, in a bicuspid, higher implant is safer because you're anchoring on the leaflet, not on the annulus. So even if you post-dilate these valves, the pop-out chance goes down. So it's better to place higher in bicuspid anatomies.
The other thing that means I'm in my preliminary experience, you may say that I find it very difficult to analyze the calcification and the real type of bicuspid on CT when you get a CT to see whether it is type 1 or type 2. Is it easy or am I that I am not understanding it? So I felt that it's not that easy, and it's sometimes you don't know what exactly it is. Is that correct?
Yeah. Once you look at few pictures, sir, if you look at, it's like type 0, type 1, type 2.
Type
So
2
if
is
you
very
see,
rare anyway.
yeah. So if you see
Type 0 is very easy. Once you get that RAFE,
no RAFE, absence of RAFE.
the absence of RAFE is good. That is easy. Other ones, are they?
What you do is you look at both systolic and diastolic frame. So what you do during systole, if the RAFE is there but the leaflets are not splitting. But I think, sir, once you look at few pictures, just 5 or 6 of them, it's going to be easy.
I think you have to sit with a radiologist once you start doing TAVI. It's very important, because otherwise you, as you said, you have to see your own CTs.
Absolutely, I agree that, yeah. Now with the COVID period, it's not possible to sit with anybody.
Yeah,
yourself.
So
how is TAVI in COVID? How is it? Are there any differences in COVID?
No, it's just that patient has to pay extra for COVID test.
And the PPEs.
I think there is one question from Ajit Desai. Is to Nitin. In a LFLG with a coronary artery disease, a kinetic dystonic segment can echo predict the improvement in the left ventricular fraction, either TAVR, if the dobutamine echo is not very helpful. That's a question from Dr. Ajit Desai, our colleague.
I think at the low dose, probably at the low dose, if you show some improvement in contractility, probably you know that there is a viability. I think that's the only way it can help.
Can be helpful. Actually.
It can help, yeah. But I think it's very challenging, because especially in hypertrophied myocardium, it is very difficult to detect. But one thing is there, if the thickness is well preserved, like say 6 millimeter or more, probably we have to assume that there is a viability. But something like 3 millimeter, 4 millimeter myocardium and highly echogenic, it is very unlikely that there would be a viability. So one can make a educated guess on that.
I have a question to Dr. Ravindra.
Yes, sir.
What is the incidence of subclinical leaflet thrombosis in both the valves?
So if you look at the data which was shown by Dr. Burkle, where the incidence of subclinical leaflet thrombosis was almost around 20 to 24% at 30 days, and around 20% at almost 1 year. So if you ask me head-to-head comparison between a balloon expandable and self-expandable, I don't remember offhand right now, but yes, it is higher in a balloon expandable valve compared to a self-expandable valve. It is higher in a balloon expandable valve. It is higher in both small annulus and in large annulus. It is higher in patients with low flow, low gradient severe AS, and it is higher in a valve-in-valve patients in a smaller annulus. Yes, compared to both the valves, it is higher in balloon expandable valves. But does it translate into any clinical outcome? Yeah. No. Up till 5-year follow-up, the valve hemodynamics comparing SAPIEN 3 versus a surgical AVR, it remains same, in fact better. So we don't know what to understand or what to make out of this halt and ham. But I think the way it will change is once we routinely start giving anticoagulation for low-risk TAVR and valve-in-valve TAVR. This should go away. The reason why anticoagulation was not used in TAVR patients is, if you look at the partner 1 or the high-risk trial, the average age was 84. So nobody wanted to start them on anticoagulation post-TAVR and they were being done through 20 French, 22 French, cut down, surgical cut downs, transapical, transaortic. But once we move down to the low-risk patients, we'll have to implement our therapy and change and practice the same way as you would practice for a surgical AVR. What do you think?
In that case, you do a follow-up with CT, or what is the protocol?
No, echo.
Echo can pick
so
up
you
these
follow
things?
it. Yes. So on echo, what do you do? If the gradients increase from baseline, suppose my patient's a baseline gradient were normal, at 6 months follow-up was normal, and at 1 year follow-up was normal. Now I see that all of a sudden there is an increase in mean gradient by more than 10 or 20 millimeters of mercury. I would just put them on anticoagulation for 3 months, maintain an INR of 2 to 3. Because investigations which you need is a 4D CT. Rather than that, you would use your clinical sense, go ahead and give them an anticoagulation suspecting a subclinical leaflet thrombosis.
I'm going to ask you an interesting discussion on this because this is a very interesting topic about antiplatelet. You got it on. So now, have we moved on to? We generally have moved on to a single antiplatelet in a regular TAVR. Am I right?
No,
We're
no,
still
no.
using dual antiplatelet.
Dual antiplatelet for 3 to 6 months. In fact, I use anticoagulation for all my young TAVRs for 3 months. Young means, anybody who's between 70 and 75.
Okay. And
but it's not the guidelines. It's not the guidelines. Otherwise, I would use dual antiplatelet for 3 to 6 months and then just single antiplatelet.
And valve and valve, because valve and valve indication of anticoagulation has only been in smaller valve and valves and probably a pre-existing atrial fibrillation. Otherwise, they still use single or double antiplatelet.
Dual antiplatelet. So if I'm using a valve in valve for a smaller valve, I would put them on anticoagulation for 3 months. I think the guidelines will change. See, one of the reasons why these patients might have, late stroke is because of thrombus which might form in the dead space. When you put a valve, the leaflet is still there, the calcium is still there, there is a strut frame which is there, there is a different type of eddy currents which start, forming. I strongly feel if your patient does not have an indication, contraindication, he should be on 3 months of anticoagulation so that the entire thing that starts getting endothelialized.
Like a surgical bypass.
Yeah, I don't do a study.
At least minimum 3 months what you want.
Come up with.
I think Dr. Kane sir, we already exceeded 15 minutes. I think we have one last question, something, and I think we'll have to some comments from the Kirti and Nityan Samte. And
Kirti requested, he has some other engagement also, so I said he may go because I knew that.
Can I ask one question?
Yeah, please go ahead.
Dr. Kirti, Dr. Rao and Dr. Mehta, Harish Mehta, what about patients coming with CAD post-TAVR? How easy or how easy is it to do, or what is that I have to understand?
Okay.
So what I'll do is, I haven't shared that live case video which I had done, because in that live case I had shown how to use a self-expanding valve so that the future coronary access is easier. Now, I'm going to share that video. So number one, if you have a balloon expandable valve, your coronary access is how you would do for all your routine coronary cases, because the valve is sub-coronary.
No, my question is not that. Yeah. My question is, you have done the valve replacement. Now, after 4 years, 5 years,
patient develops coronary artery
disease, and it comes to us.
If your patient has a balloon expandable valve, you can access your coronary arteries how you would access for all of them, because the valve frame is subcoronary. The problem happens in a self-expanding valve. That's why now if I'm implanting a self-expanding valve, I would implant in such a way that my coronary access is easier. And that is what I have shown in that live case. I'm going to share the video with you. But what you do is you take one size smaller guide. It will go through the diamond and will enter into the left sinus. But the problem happens if there is a skirt, in post, we call it as a post in front of the coronary artery. Then what you do is you put your guide, take a non-selective picture. Then you try to wire into the coronary artery. Over the wire, you advance a balloon and a guide liner. Now keep your guide liner in the left main and go ahead and do all your interventions through the guide liner which is placed if your guide cannot go beyond the strut. So the challenge only happens in a self-expandable valve, but the way you implant it is so that the post is not in front of the coronary artery. But
Ramesh,
we have one or two questions, and I think
there are a lot of questions from the audience.
There is actually.
So can we take some more time?
I think one or two. I think that Dr. Gupta ji is telling that we have already exceeded by 20 minutes. So let us finish off in the next 5 minutes. Okay.
Sure? Okay. So this is a question from Ajit Desai. I'll just read it out.
I have taken that.
Which one was that?
That was there.
Classification and all.
Ajay Ponde's question I have taken already. Dheeraj stage question also I have taken. This one question has come from what is a shallow shallow sinus of Valsalva in terms of numbers? Can Ravindra highlight that? That's one question
So
has come from Dheeraj.
if a sinus or Valsalva diameter is smaller than the valve which is being implanted, it is a shallow sinus. For a 23 millimeter valve, a 23 millimeter sinus is shallow. For a 26 millimeter valve, a 26 millimeter sinus is shallow. For a 29 millimeter valve, a 29 millimeter sinus is shallow. So in short, a sinus equivalent to the size of the valve is a shallow sinus.
Okay, so I think we are towards the end. So Ramesh, you can take over.
I think we had a very excellent session by both the speaker, Nitin and Ravindra Singh. We have highlighted, and both the moderators, the Kane sir and Anand Rao, we have highlighted, and our expert panelists, Kirti and Dr. Harish Mehta, have done an excellent job. I think with thanks to all the audience, and especially thanks to CSI, but I also must thank the Edwards, the Harshal from the Edwards who cooperated, and Sajid from Torrent, who with a very short notice helped us to get a platform for this, and Harshal who coordinated with all with Ravind, and of course Ravind sparing this time with us, and of course we'll be seeing you more in Mumbai, I think more often for these cases actually, and hope you all the best. Thank you all of you. And Dr. Gupta wants to say anything? Our next program, Kane sir is going to have something. You can announce it today about the 25th program.
We are having a heart failure update on 25th. So we'll come with the program and the details. So that's lined up for CSI Mumbai chapter. Of course, there are others which are others. So I don't want to announce that on this. But
I want
through
to
CSI on 25th.
I think
and
anybody
Ravinder, thanks a lot.
Sajid
Thank you, sir. Thank you.
No, I really want to thank you all of you.
I want to request whether the link of this meeting will be available because Ravindra
yes, they have recorded. I think they are.
Ravindra Rao's lecture today was outstanding.
I think Torrent people have recorded, and we can put in a YouTube or something like that. We can do.
I had asked him. He said he'll give the recording.
Yes, recording will be there, and I think we can circulate it to people who could not attend for some other commitment. I think we can definitely have a recorded version when we circulate it on some platform. Definitely.
So we will share you the link of the recording. Yeah.
Dr. Gupta wants to say something or what?
Dr. S.B. Gupta sir, anything from your side?
Just to say thank you to the speakers. Dr. Ravinder has done. I have talked to him a few days back. He has done an excellent presentation today, and Dr. Nitin Burkle, I know him so well. For any echo talk, he's always there. So thank you very much, Dr. Ravinder and Dr. Nitin, Dr. Kane and Dr. Anand Rao for moderating the session, and Dr. Harish and Dr. Kirti for being the expert today, and Dr. Ramesh for, I think, being a good chairperson for this meeting, and Sajid from Torrent and Mr. Harshal from Edward. Thank you very much. All of you.
Thank you so much.
Thank you, Ajit.
Thanks all. Thanks everybody.
See you on 25th again.
Bye.
Thank you.
Bye. Thank you.
Thanks everybody.
Bye, Ravindra. Happy tower for you.
Thank you.
Thank you. Thank you.
Nitin, bye, Nitin.